Hi, everybody. Thank you very much for joining us tonight and for giving up an hour of your Monday evening to attend what I think will be a really interesting presentation and question and answer session from Mr. Rishi Chana. The topic for today is to cover the indications for partial knee replacement and then what a patient may expect, both in terms of the procedure that they undergo and also the kind of outcomes that people are able to receive from partial knee replacements. Now, Mr. Chana is based around Windsor and London in the southeast of England, and he's a specialist in hip replacements and knee replacements and also joint preservation surgery, which was the topic of the talk that we did a couple of weeks ago. He's very accomplished, I think, in keeping strong observance on the kind of technologies that are coming through and then reflecting on which ones to bring into the practice and then making sure that he's fully trained. He then follows up his results and goes on to teach others. And two areas of interest, one which isn't relevant to this talk, is the use of biologic materials to help regenerate tissue if the objective is joint preservation. And for joint replacement or partial knee replacement, robotics, which is a technique that's really been pioneered over the last 5 years, I'd say, in orthopedic surgery, and there's tremendous advances in both accuracy and the reproducibility of the surgery. But I'll leave Mr. Rishi Chana to cover that. So let me hand over to yourself. Thank you very much for everybody joining.
Thanks very much, Richard. Really appreciate the introduction. So thank you, everyone, and welcome. Thank you for your time. I appreciate that you've taken this time out to come and join me for the talk. If you have any questions, please don't hesitate to put them through, and we can address them as we go through the talk, the discussion, and we'll have time for discussion and questions afterwards as well. So really what we're talking about are partial knee replacement indications, what patients would expect as an outcome, what the journey looks like, and what expectations can be of this type of surgery. So let's just crack on with different types of wear patterns of the knee. Really, the most common predominant factor is osteoarthritis, which is the one on the left-hand side. It's about 70% of incidence of knee wear and tear, and this is typical, what I would call lifestyle or life just taking us through, the cartilage wearing away. You can see a nice pristine knee on the left side with nice, beautiful hyaline cartilage, and then different sections of the knee then start to wear out. And what we'll find in a pattern here is the knee has three compartments. There's the inside, the outside, and the patellofemoral, which is the kneecap joint. And because of alignment issues, because of lifestyle issues, genetic issues, we all sort of wear out one bit more than the other. And it's about whether we can address and focus on that one bit that's the major problem and try and preserve the other 2/3 of the joint moving forward. So that's really the emphasis of this talk. So most people with osteoarthritis, if caught in time, will have one compartment more worn out than the other. And osteoarthritis is a really good indication for having a partial knee replacement. The other two common ones are post-injury. Now, this can be through sporting injuries or trauma, if you've had an accident or a car accident. And again, one area of the joint has taken particular trauma, and that has then resulted in failure of that joint. These typically result in pain patterns that give rise to localized discomfort and pain. If it's your inner aspect of the knee, then you're going to have pain, dull toothache pain, getting worse at night on the inside of your knee. The kneecap going up and down stairs or the outside half of the joint actually then is not so painful, and that's the kind of history that we're looking for. The image on the right with the redness, that's inflammatory arthritis. Now, this is a very different component. This is gout, pseudo-gout, patients who have rheumatoid arthritis where the body is attacking its own cartilage because of the synovial membrane, which is basically the membrane that produces fluid inside the knee. The knee is the biggest joint in the body. It's got a huge pocket of this membrane. and the membrane becomes inflamed and starts to attack the joint. And the problem is the whole joint gets affected. So patients with inflammatory arthritis, with rheumatoid arthritis or with gout, generally the problem is that they then don't go on to have one focal area that's worn out. They in fact then get bigger areas, more global areas that are worn out. So Richard, maybe you could just post the first poll question just to say where we are with understanding of arthritis. And then, so I'll carry on with wear patterns. So you can see on the left-hand side, that's a nice pristine joint, a knee joint, the thigh bone and the lower leg bone, the tibia, and the space in between is cartilage. So we're looking for a nice even space of cartilage in the inner and outer aspect. You can't see the patellofemoral joint here, but we'll talk about that in a minute. And then you can start to see in the middle slide, there is some progressive wear. And on the right-hand side, the inner aspect of that knee has failed. The cartilage has gone, and you've got bone-on-bone arthritis in that inner compartment. The outside compartment, there's still that cartilage space. So what we can do is focus on trying to do something about taking and offloading the inner compartment cartilage and basically loading the outer compartment cartilage. So let's use the cartilage that we have and either replace or offload the failed part of that joint. Again, now looking at patellofemoral wear, this is the kneecap. On the left-hand side, you can see skyline views of the kneecap sitting. It's a tongue and groove joint, and it's a sliding joint. And the lower left-hand side is a lateral view, it's a sideline view. And you can see that there's lots of space here between the two bones. As you come into the middle slides, the pictures, you can see that actually the joint space is reduced. There's no space now, there's no gap, and you've got that typical bone on bone. So patients who have patellofemoral arthritis struggle with fixed flexion deformities. Basically, the knee doesn't fully bend, it doesn't fully straighten. You'll find going up and down stairs is very painful. There's a lot of crunching and grinding. And patients tend to get a lot of pain going into the right in the front of the knee, going right through into the back of the knee as well. And patients get a lot of what we call referred pain. So even though it's the kneecap pain that's causing the arthritis, they can feel pain in the back of the knee as the pressure goes through. On the right-hand side, you can now see, actually, this is a patellofemoral replacement. So we've replaced the groove with a nice metal implant, and there's a plastic button that recreates the joint space, and that replaces the cartilage. So we've saved 2/3 of this patient's joint by not doing a full knee replacement, but we have moved on and replaced the patellofemoral joint. Patients who have these issues, you will see change in alignment of the leg. So the patient themselves will say, I've noticed my right leg is bowing in a bit more. In this patient, it's the left side. So you'll say the left leg starts to bow in more because the inner aspect is wearing out. Or if you've lost cartilage on the lateral aspect, the patient will say, I've noticed my left knee is becoming more knock-kneed, it's changing shape. And actually, you can even offload these patients and say, does that feel better? So we'll talk about that in a minute. So this is tricompartmental arthritis. The image that you're seeing here on the left, when the whole knee or 2/3 of the knee starts to fail and there's no space of cartilage on the inner or outer aspect, then unfortunately there's no point trying to do partial knee replacements. And this patient goes on to have a full total knee replacement. The main difference between a total knee replacement and a partial knee replacement really is the invasiveness. It's how we do the surgery, and it's how big the cut is, and actually then how painful the recovery is, how long the recovery process takes afterwards. It's total knee replacements are a bigger cut. We have to open up the quadriceps muscle, which is the main thigh muscle in the front, and that causes pain. It takes about 6 to 12 weeks for that muscle to start to recover. And that's the main problem with a total knee replacement. It's pain and stiffness, and it's that period of time taken to get over that. So if we can avoid that and save the patient their own natural joint, what we then do is we actually have the option of doing a total knee replacement 10 or 15 years later. So we're all about saving real estate, buying more time, and improving function. So this is the MAKO total knee robotic arm surgery machine. I'm a certified MAKO surgeon. We do hip and knees in the Princess Margaret Hospital, Windsor. You're very welcome to visit my website for further information after this talk. So really what this is it's an arm that's attached to the saw, and I'm the surgeon. I'm in charge. Nothing happens without me telling the robot I want to go ahead and pressing the trigger. So it's not that the robot will ever become uncontrollable. So let's just go through the history of what this is. We're always looking for, as Richard said, evidence-based landmark improvements. We don't want to be the first people doing these things. Some of them are experimental. Some of these things don't work. But actually, this has been in evolution for about 15 years. We've got good, strong 5-year data showing that this has reliable, reproducible results every time. So to me, this is a paradigm shift from an analog to a digital era. If you go back in time and remember in the 1980s when you're driving your car, you had a roadmap that was physically in a book, and you had to open the book and say, right, this is where I think I'm going, but actually a lot of times people will get lost because where you think you are and where you actually physically are not always the same. And to me, this technology is a bit more like being in a brand new Tesla car with satellite navigation, and it's even got an autopilot that it will tell you, I've got the lane control and I know where I am. It's not I'm thinking where I am. I know 100% this is where we are. The second advantage is less invasive surgery because the cuts are smaller. We don't go through that muscle I was talking about. There's less inflammation. And actually, because of that, there's less pain and there's a much faster recovery, as you'll see. So this has been around since 2006. We are now in our 3rd generation of model. So it's not a newish sort of technology. So what happens? What we do is we always see the patient in clinic. We take a full history and examination to make sure that we get the correct diagnosis. And we do x-rays and an MRI sometimes to confirm that. We then go through all the different treatment options, and we always start with the most conservative treatments first, of painkillers, lifestyle changes, physiotherapy. There's a lot of evidence that shows that physical therapy does improve the patient's outcome, and with these sort of changes in multiple factors, actually you can really add in important changes and make a big difference. The other thing that I want to mention is the use of an offloader knee brace. Now there are braces out there. One company is called the Ossor offloader knee brace. And again, if you look at my website, there's a lot of information on this. And when patients have one compartment, let's say the inner compartment that's worn out, what we can do is use the knee brace, which is spring loaded, to basically jack open the knee, get the alignment correct again, and actually it uses and it mimics what a partial knee replacement would be like. So it's a really good test of trying this patient out and saying, look, will this work for you? We'll try the brace first because you've got nothing to lose. And if it works and you're fed up with the brace, then we'll go ahead with the surgery. So then we already know we're going to get a good result without even starting. Have a look at my website on that. There's a lot of information on there about the braces. Once we've made a decision to go ahead, we then get a CT scan, and we're basically marrying up the virtual reality of the knee model to the real patient. And then we move forward with surgery and pre-op planning. So I'm just going to take you through that model now. So we get a multiple slice CT, so a CAT scan, taking lots of pictures of the patient's knee. That then comes together to build a virtual 3D model. That 3D model then goes into the computer's brain, and this is the setup of the theaters. So you can see the leg here. On the leg, there are 2 little portals or arrays, which basically tell the computer's eyes, which are up on the top left-hand corner, the little sensors you see there, and they basically tell the computer the position of the knee and the leg. On the screen, I can see what the computer sees, and then we can start planning things, and the robot is there all covered and protected and sterilized. What we then do is we then marry up the reality along with the virtual reality of what the computer sees in its virtual brain. We then allow dynamic joint balancing, which means really on the table, before we even start making the cuts, we can plan where we want to put the implants. We get the alignment right. We can move the knee and see how it feels. Is it going to be a bit tight? We get it absolutely down to absolute perfection on the table. We then start to plan the cuts. So basically, what you see on the left side is the green is basically what the computer says, if you want to put the implant in this position, you can take away this bone, and you see the little, the green lanes on each side of the blade. That is a little bit like bowling with the lane barriers up. It basically means that if you try and go either side of that, the computer and the robot will shut the blade off. So it will not allow me to make a bad cut. The cut will always be 100% accurate in the position that I want it to be in. And that's really the beauty of this. So this is the setup again. You can see the bone, the arrays, and the saw blade. You can see exactly what I need to see for planning and for the operation itself. And then we move forward and actually do the surgery. So what's so important about this? The graph on the left-hand side shows you the accuracy of the MAKO knee replacements. So when people do something like shooting or throw darts at a dartboard, you want nice tight grouping. You want accuracy and reproducibility every time. And you can see that that graph has very low variability, which means it's 100% accurate. The graph on the right-hand side has a lot of variability, which means that actually it's not that accurate. It's a bit like throwing darts at a dartboard with your eyes open or closed. I certainly prefer to have it open, and it's 3 to 5 times more precise with the robot than manually. So I don't see any point in not doing this operation without the robot. So we can then do enhanced planning. We do personalized dynamic joint balancing and accurate cuts. So you, as a patient, then end up having a personalized, customized knee replacement to suit your individual needs, your skeleton needs, and it's suited down to your bone. It's not a typical off-the-shelf, one-size-fits-all solution. And that's the really important thing with partial knee replacements, is that they're very technically demanding. And the problem is that if it's not 100% right, then patients can complain. And that's where they're notorious, and they have sometimes earned a bad reputation about not having as good an outcome or as long a survivorship, because if they're not put in right, they can cause problems. So with the MAKO, you can see that there's much better pain relief. You can see the graph on the top right having lower pain scores right from the outset, and a very good patient satisfaction. Can we play the video, please, Richard? Thank you. So this is a little patient journey of a patient that's had it. He had both sides done. We had waited for 5 years.
Yes. So Jeff, you've had bilateral MAKO unicompartmental medial knee replacements.
Your legs are nice.
Your legs are nice. Straight. How are you feeling in yourself? Excellent.
Any pain at all?
Any pain at all? No, not at all. Really good. Just lift the leg and bend for me. And bend it.
Very good.
Very good.
And the other one.
And the other one, please.
And bend it.
And bend it.
Excellent.
Excellent.
Good.
Good. We're going to get you walking tomorrow.
Oh, brilliant.
Oh, brilliant.
You can walk without energy.
Bilateral
MAKO
unicompartmental knee replacements.
And
walking without any problem at all.
Just one day
after.
That's great.
That's great.
Perfect.
Perfect.
Okay.
Lovely.
Lovely.
Thank you very much for that. So that was a typical patient journey of what this type of surgery can do and achieve. That patient had both sides, both the left and the right inner aspect knee replacement, which is exactly what you're seeing here on this slide. And as you saw, he had minimal pain straight away. He said the knees felt natural and normal almost within 48 hours. He was walking the next day without any crutches. At 2 weeks, he walked in like almost nothing had happened. And at 6 weeks, this gentleman was doing 45-minute spin classes in the gym. So that is not what a knee replacement journey is like at all. If this patient had bilateral knee replacements, he would be using crutches, he would have a lot of pain and a lot of discomfort. So for me, this is a totally different ball game, and it is one level above the difference between maybe an athlete and an average sportsman on performance. So this really, to me, is the Formula One of knee replacements and function. So this is what we see when we're doing the balancing to make sure we get it absolutely spot on and 100% accurate. This is another graph just showing you the degree of accuracy. The yellow is the MAKO, the manual is gray. You can see it's a much more accurate method of getting it right. This is the first one that I did, and actually the 100th one that I do will look just as good, which is great, because you want to be able to do the same level of high level excellent function right from the outset and keep going with it. One of the major issues with partial knee replacements is what we call survivorship. Now, there's two factors that affect survivorship. One is if it's put in badly and it doesn't work properly, then the patient's never happy with it. And 3 years later or 5 years later, they come back and they keep coming back saying, my knee's not right, I'm not happy with it. Or they see someone else and they then convert that partial into a full knee replacement. And that's what happens with manuals a lot. There is about a 6 to 7% revision rate within the first 5 years because of these technical problems. That does not happen with the MAKO robot assisted surgery because they are put in a good position and a strong position that is correct for that patient. The second thing is that the rest of the knee, the other 2/3 of the knee do continue to wear out. But that process takes 15 years. So you've then given the patient excellent function with a partial knee replacement. You've bought them another 15 years down the line, and they can always have a total knee replacement at that time if the rest of the knee starts to wear out and cause a problem. So, and they have really good function with the total knee replacement at that point, which is another advantage. So may we have the last video, please?
My name is Mr. Rishi Chana.
My name is Mr. Rishi Chana. I'm a hip and knee orthopedic consultant specialist
working at Princess Margaret Hospital.
This is a huge step forward. It allows us to plan each operation into a bespoke procedure for that patient, so they get a customized operation. It gives us 100% accuracy for where we're putting the position of the implants. This also means a less invasive operation. The recovery is faster, there's less pain afterwards, and the improvements in the function is also there. There's lots of evidence to show that.
I'm Henry Burke. I'm a consultant orthopedic surgeon and a specialist knee surgeon, and I consult here at Princess Margaret Hospital. So this wonderful new technology is going to allow us to do knee replacement and partial knee replacement surgery better and more precisely than we ever have done before. We're seeing that the less soft tissue disruption and the precision of cuts means the patient has not just less pain, but they lose less blood. That big second advantage is that once the patient gets up after their surgery.
Thank you. As Henry was saying, the second thing is actually you lose less blood, it's less painful, and again, that all gives enhanced recovery and much better outcomes. Really, it's about having your own individualized, customized plan. It's millimeter and angle single degree accuracy. And really, we're almost seeing the results in the clinic. You can almost see your x-ray or the plan in the clinic before we even start. And with the osteo knee brace, if your patient or yourself are not sure about it, it's a great and safe way of testing the waters and seeing whether this will work or not. This is a patient, another lady, who is at 6 weeks. And again, you can see that degree of flexion. Because there's no inflammation, the pain is less, the cut is much smaller. We don't go through the quadriceps muscle, and patients generally and invariably do really, really well. And that's coming through on the evidence as we speak at the moment. So please do feel free to visit my website. I'm on Instagram and LinkedIn, and I've got a YouTube channel as well showcasing more of these sort of patients. So if you want to see what they're like and how they feel afterwards, they will be able to show you on these social media sites. Thank you. Let's take some questions, shall we, please? So one question from Philip is, what we consider the optimal age for a partial replacement to be fitted? Any patient characteristics? So thanks, Philip. I think age is very difficult. I don't have a top end age. I think the oldest lady I've done was probably in her 80s. And again, it's about the history examination and the mechanical finding. So if patients have got the issue of a single compartment that's failing, and they've failed conservative options, then really a partial knee replacement is a good idea. Another option in your patients who are young, let's say a 30-year-old patient who's got medial compartmental wear, if there's problems on the inside aspect, sometimes you can do something called an osteotomy, which is basically an operation that does the same thing as the spring brace. You have to break the bone, reset the leg in a way that you then load the outside compartment and offload the inside compartment. Now, that operation is a 3-month recovery. I've talked to patients who had that operation and they never forget it. It's a really big, awful operation. So in patients who actually have that, who are young, I would recommend they carry on with the brace. And if they get sick of the brace, you can always consider an osteotomy. But also, again, partial knee replacements, I think, if they're going to last 15 to 20 years, even if you're in your 40s and need something like that, it's enough to get you through. Right, so any more questions? Let's just carry on through. There is partial knee replacement. When would be a good time to get the other one done? So yeah, so part of the problem in lockdown at the moment is I think we're globally seeing that our patients are not enjoying the same level of rehab and recovery because the physiotherapists are not there. The mentorship, physically putting their hands on and getting through with things, having hydrotherapy and access to swimming and outdoor activities in the gym, that's unfortunately part of the issue. Hopefully, fingers crossed, that's going to improve now. But really, once you get back into things, I think you can carry on. I think having partial knee replacements stepped between stages, I would say I think 6 weeks is a good time to space it, because that then basically means that you have recovered enough, you've got through the inflammatory phase, and then you can move forward. Now, 6 weeks would be something that I'd say that's pre-coronavirus. The issue now with coronavirus is that your body goes into what we call a catabolic state, which means it's trying to heal. It's had a controlled trauma or an injury, and it takes time to heal, which means your immune system can be driven down. So now I would say you have to be very careful about stepping the surgery. So I would probably say 3 months apart, just to be 100% sure. Options with anesthetic, there are lots of different options. My preferred combination is what we call a spinal with sedation. So the patient is not actually fully asleep. You don't need to be intubated, which again minimizes the aerosol risk. You can have a localized spinal, which basically is short acting, as you saw with Jeff there. He, 2 hours after the operation, was moving his leg. So the the spinal only lasts for 2 or 3 hours. It's a nice way of waking up. The leg starts to wake up. The patient is awake all the way through. They have a little bit of sedation on board just so that they're comfortable through the operation, but they're breathing on their own. They're awake and they are semi-conscious of what's happening, but you can turn that down if we need to. But again, that's very safe from a patient perspective, and also now from an aerosol perspective, looking at coronavirus, that's also a very safe way of going around things. So I can see from Karen that she's 4 months down the line, doing really well, walking for an hour, cycling for 3. That's fantastic. The operation takes about 85 minutes. So it normally takes about 65 to 70 minutes on a manual. With the robot, because you're doing a little bit more time with registration, there are 1 or 2 more steps. So it's not a quicker surgery, it's a more efficient surgery in delivering that high quality outcome, that really good patient-centric customized solution with really good results and excellent pain relief. The post-operative journey that the patient experiences is second to none. And that's why I'm sold by it, because what I've seen from my patients telling me literally the next day that their knee feels right straight away, and then they continue to take off after that. It's fantastic. Any more questions, guys? So, do you think some form of intra-articulating load monitoring would improve results even further? It's a different, it's a difficult one. I think that I'm not entirely sure, how to measure that. So when we're doing the surgery, we are monitoring the pressure of how tight or loose the knee feels when we're actually doing the surgery. So we get the balance right through the surgery. And I think knowing that we've got the balance right and knowing that the patient then feels good about their knee, and you can see that on the x-rays as well, on the post-operative x-ray, what you saw, I'm just going to go back to sharing the screen. What we're looking for as surgeons is that actually you're trying to mimic that open joint space again. See? So you can see on this knee that was replaced, the one on the left side, the space between is now balanced. It's back. It's equal on both sides, and it's not that bone-on-bone arthritis. So once you've achieved that balance, I'm happy that the intra-articular load monitoring is there. So so we're doing it on the table, and then we know it's continuing all the way. So physio programs, have a look at my website, have a look at the post-op physiotherapy protocols, and everyone will have their own sort of preferred methods as well. How's this with existing metal plates? So patients who've had plates and ACL reconstructions, it's a CT scan. So when we plan the operation, we can actually plan whether or not the cut is going to be affected by any existing metalwork. So we've done operations on patients with ACL screws, with metal plates in there, and actually we can tell straight away before or not whether we need to go in and take the metalwork out or not. Any regular x-ray monitoring of runners to check joint narrowing? It's a difficult, Simon, thank you for that question. I think the problem, Simon, is that once you start to see the joint narrowing, the horse is already bolted. The problem is to start to see joint space narrowing, you have to have lost at least 30 to 50% of the cartilage in that joint already. So by doing MRI scans, you can certainly look and think about whether or not this is an issue. For me, I think people who run love to do it, and they don't want to get told not to run. So what we tend to manage with them is we sort of say, look, don't just run, do strength work, do some cross-training work, vary your exercise routine so that you are not just overloading the knees and not just running. A lot of runners actually have very poor core strength and need to spend time on improving those core gluteal muscle strength and conditioning. And actually, a lot of runners get injuries because they don't have that good core strength. So by addressing the whole global problem What we then do is reduce the risk of injury and also reduce the risk of progressive arthritis. If you want to look at the website, it's rishichana.co.uk. And yeah, we'll put that up at the end. Sports after a unicompartmental, I would recommend anything that has a regular lower impact type of thing. So tennis, cycling. If you wanted to do a little bit of running, I think that's not terrible, but I wouldn't run regular long distances on these, because you've got to think of them as a change of tires. It's metal on plastic. It has a finite wear rate and a finite life. And I think you have to take the view that do you want to go on a Sunday drive and make it last 15 to 20 years, or take it on the Grand Prix track and make it run out really quickly. Okay, any other questions, guys? So if there are any other follow-up questions or anything, please don't hesitate to reach out to me. You can always message me or send me an email through the New Guru website, and we'll take it from there. So thank you for your time.
Thank you very much, Mr. Chana. That was really interesting, and thank you very much to everybody for their questions and for their attention. Bye-bye.
Good evening. Cheers. Bye.